Hello everyone, my name is Louise Costello and I'm a chronic pain nurse specialist working here with the team at COPE. I am also a nurse prescriber, and today I'm going to talk to you a bit about chronic pain and the medications that we use. So the aims of this session are really just to increase your knowledge and understanding of medications that we use for pain, to provide information about pain medication to help you make appropriate decisions, to increase your confidence, and to give you an opportunity to ask questions. And I just want to acknowledge that I'm sure all of you will have had different experiences of medications. So the first question I want you to think about is, what's important to you about your pain medication? And is medication for chronic pain always helpful? So what is the purpose of medications that we use for chronic pain? Well, the main reason that we would be prescribing these medications is in an attempt to try and lessen your pain. But one of the other things that's really important but often gets forgotten is that we should also be improving your function. And what we need to make sure with all of the medications that are prescribed is that the benefits are greater than any side effects that you may get. And what can often end up being the case for many people is that although some of the medications may lessen their pain, some of the side effects are so much that they actually make their function worse, make them more drowsy or unable to do the things they want to do. So it's really a real balancing act to try and make sure that any medications that we're prescribing are giving you more benefits than they are side effects. So medications have two names. They have a brand name and they have a generic name. Now, the brand name for Panadol, the generic name would be paracetamol. For Nurofen, the generic is ibuprofen. For Voltarol is diclofenac. Paramol is codiadramol. Solpadeine is cocodamol, the lower dose. And lastly, Solpadol is cocodamol, the higher dose. So those two figures you see, the 30 in 500, is 30 milligrams of codeine and 500 milligrams of paracetamol. The reason it's important for everyone to be aware of generic and brand names is specifically in the last few years, the NHS no longer tends to prescribe over-the-counter medications due to the cost, firstly, to the patient themselves for those who are paying prescription charges, but also to the NHS. Many of these medications are very affordable over the counter. So things like paracetamol and ibuprofen, as you can see, are usually around sort of 30 or 40p. But what's important to recognise is that some of the brand names can be as much as 10 times the amount in cost of the generic. And the brand names themselves, the active ingredients are exactly the same in both. Now, sometimes some of the brand names do add other ingredients, generally things like caffeine, that can sometimes make people feel that the medication is better. But the actual active ingredient is exactly the same. So I'd always recommend going for a generic rather than a brand name. And have any of you heard of something called the placebo effect? And if so, what do you feel that is? So what we know is that it's an effect where all of us can respond to something because we think it is helping us. And it's somehow thought to be related to how our brains can modulate responses, feelings, and sensations. And in fact, 30% of all medications is thought that the effect of those medications is due to placebo effect. So even when you have a medication with active ingredients in, around 30% of the benefit you get from that medication is thought to be due to placebo. So taking a pill in the context of a patient-doctor relationship, even when you know it's a placebo, is a ritual that changes symptoms and probably activates regions of the brain that modulate those symptoms. So how many groups of pain medications do you think we have? Well, there are 5 groups of medications, plus a group of medications called adjuvants. That aren't that aren't actually pain medications, but they are medications that can help work with other medications for pain. So the groups we have are, firstly, paracetamol, which stands all on its own group. Then the next group we have is non-steroidal anti-inflammatory drugs, or NSAIDs for short. And these include things like ibuprofen, naproxen, diclofenac, celecoxib. Then we have a group, opioids, which is probably our largest group of pain medications. And this isn't all of the opioids, but this is a lot of the ones that we use generally. So codeine, dihydrocodeine, tramadol, morphine, Oramorph, Butrans, oxycodone, and fentanyl are just some of them. Then we have something called lidocaine plasters, or Versatis plasters is the brand name. And these are have local anaesthetic in them. Some patients say that they can be quite helpful. Unfortunately, it's quite difficult to get them prescribed for 2 reasons. Firstly, there's very little evidence of their effectiveness. And secondly, they're very expensive. So in fact, some GPs aren't allowed to prescribe them because of the cost. Then we have gas and air, or nitrous oxide, which obviously in chronic pain we don't tend to use because it just wouldn't work. It's too short acting, and you'd have to be walking around with a cylinder at all times. And then the final group we have are our adjuvants, and these include antidepressants and anticonvulsants. And I will go on to explain each group. So our first group, paracetamol. These are usually fairly well tolerated by most people, and they act mainly in our peripheries. They block the production of something called prostaglandins, which I will go on to explain in a further slide, but they only mildly block these prostaglandins. It is important to note that if somebody's weight is less than 50 kilograms or just under 8 stone, they should be taking a lower dose of paracetamol. So we would normally recommend probably only taking 1 tablet 4 times a day rather than 2. And that's similar to with children, we have to work out medications by their weight. And so if an adult is a lower weight than 8 stone, then they're seen to be under the safe threshold for the adult dose. It's also important to acknowledge that many other medications include paracetamol. So things like your cocodamol and your codidromol are a combination of the codeine and paracetamol. And then there are lots of other things like cold and flu remedies that include paracetamol. So just be aware of any new medication that you're taking. Just make sure if you're already on paracetamol that you're not taking more than you should be in 24 hours of the recommended daily dose. So side effects of paracetamol. The most common side effect is medication-related headaches. This generally tends to be only for those people taking regular paracetamol every day. But it's useful to be aware of, because if you do start to develop lots of headaches and you are on regular paracetamol, it could be contributing to that. So it's worth being aware of it. They do, for some people, cause some gastric irritation, and that tends to be less so than the non-steroidal anti-inflammatories, but it can still cause problems. Okay, so moving on to the non-steroidal anti-inflammatory drugs, or our NSAIDs for short. These work by the production of certain chemicals in our bodies called prostaglandins, so similar to the paracetamol. And these prostaglandins are involved in sending pain signals to the brain. So prostaglandins are produced all the time in our bodies in order to maintain normality and to protect our organs and their functions. So by taking the non-steroidal anti-inflammatory drugs, we are reducing the level of prostaglandins, and this is what causes the side effects of anti-inflammatories. So just to explain how prostaglandins work, when we have normal levels in our body, they assist us in the development of gastric mucus. They maintain our renal function. They maintain our airway patency, and they assist us with our platelet function, so our red blood cells. So if we are taking any of the non-steroidal anti-inflammatory drugs regularly, the side effect of these is that they reduce our prostaglandins. So with reduced levels of prostaglandins, this puts us at risk of things like acid reflux, gastritis, and bleeding in the gut. Because as you can see, when there are normal levels, that's what helps to produce the mucus. So by reducing them, we produce less mucus, and therefore we're at risk of all these other side effects. And longer term, people can even develop peptic ulcers. So if you are taking these medications regularly, you should be on a proton pump inhibitor, such as omeprazole or lansoprazole, which are there to try and protect your stomach. And just be aware of those side effects if there are any that you may be noticing in yourself. The non-steroidals also reduce can reduce our renal function. They can cause our blood pressure to be increased, and longer term, you can be at risk of things like heart failure, renal failure, and diabetes. They can also cause problems with the lungs, so they can trigger asthma attacks, which is why people with asthma often can't take non-steroidal anti-inflammatories, and they can also cause wheeziness. The prostaglandins can also influence the clotting in our blood. So when we're taking non-steroidals, that can put us at increased risk of bleeding and bruising. And longer term, that may be an increased risk of things such as heart attack and stroke. So moving on to our next group of medications is our opioids. Opioid is a term used broadly to describe all compounds that work at the opioid receptors. Opioids come from the opium poppy. And opioids bind to our opioid receptors in the central nervous system, so in your brain and your spinal cord. And they mimic the action of the body's own endogenous opioids, so our endorphins and our enkephalins. Unfortunately, we also have opioid receptors in our gut, which is why opioids can often cause constipation. And we also acknowledge that opioids are not suitable for all types of pain. So in the last few years, there's been a lot of research into opioids. One of the new findings is that opioids can actually cause increased pain or can make us more sensitive to pain. So what we learn about pain is that if we take medications, generally, they tend to make us feel better. However, this is only true after you have had surgery or an injury that will heal in a few days or a few weeks. What many people do not know is that if you use opioids for more than a few weeks, it's likely to make you more sensitive to pain and to increase your pain levels. Opioids can provide relief by blocking pain. However, your body then reacts by increasing the number of opioid receptors in order to try and get the pain signal through again. So when the drug wears off, you will experience increased pain. If you continue to take opioids over time, they become less and less effective. The pain keeps increasing, not due to an injury, but because of the opioids themselves. In addition, our bodies have natural opioids called endorphins. If your body becomes used to opioid pain medication, its ability to create and use natural endorphins will decrease. This makes you lose the ability to reduce pain on your own. So, there have been concerns over opioids for some time, particularly if you are on them longer term and on higher doses. So the British Pain Society has advised a maximum dose equivalent of 120 milligrams of morphine daily. Anything above this puts you at increased risk of harm, but with no greater benefits. Just to be aware that opioids, if you're taking them longer term, they can impact and have an effect on our endocrine system. So they affect our hormone profiles. They can also affect our immune system and make us more susceptible to colds and flus. And as I described earlier, they can also contribute to something called opioid-induced hyperalgesia, which is the posh name for making the opioids themselves are making you more sensitive to the pain. So thinking about adjuvants, these are medications that are not analgesics, but they can have an analgesic effect. They act primarily within the pain pathways of the central nervous system, and they work in synergy with other analgesics to enhance their effectiveness. So we have two main groups of adjuvants. The first one is antidepressants. So the main ones that we tend to use for pain are amitriptyline, duloxetine, and mirtazapine. So amitriptyline is the first line, gold standard for pain. And this is one of the older tricyclic antidepressants. Some people tolerate it fairly well. Others find it has side effects they don't like. Duloxetine is a newer antidepressant, and it's one of the serotonin reuptake inhibitors. So it's usually meant to work quite well for people with fibromyalgia type pain, so that all over kind of pain. And then another one that we sometimes use is mirtazapine, although this one tends to have quite a high side effect profile, particularly a lot of drowsiness, which may or may not be beneficial to some people. Antidepressants are a group of drugs that we do quite like using for managing pain, simply because they target pain in 3 areas, as opposed to general painkillers that tend to just target pain itself. So with antidepressants, they will often help with the nerve type pain, as I described earlier. They can also help improve our mood, which is inevitably generally quite low when people are living with chronic pain. And they can sometimes have that side effect of drowsiness, so they can help with sleep. So they can be very helpful for some people. Now, another group of adjuvants that we have are anticonvulsants. So these are medications that were originally and are still used for people with epilepsy to try and prevent seizures, but they were found to be helpful for people with nerve type pain. So we've got gabapentin, pregabalin, and carbamazepine. Again, for some people, they can be helpful, although I would say that most of the anticonvulsants have quite a high side effect profile that people often struggle with. Now, both these groups of drugs, antidepressants and anticonvulsants, a bit like opioids, your body becomes dependent on them. And so once you are on them, it is not recommended that you suddenly stop them. They should be slowly reduced so that your body can get time to get used to not being on them. Some other medications that come up sometimes, there's something called capsaicin cream, which is a pepper-based cream, similar to deep heat, but much stronger. So for those of you who find heat very helpful, this might be something that's worth considering. Now, it comes in 2 doses. The lower dose was available over the counter, so from a pharmacy, and you had to get the higher dose prescribed. But I've been reliably informed that recently there's been problems with the production of it, and so I think at the moment all of them have to be prescribed by your GP. Then we have something called diazepam. So this medication is not one that we tend to recommend. It can be helpful for muscle spasms to help relax the muscles. Unfortunately, it has a central effect on relaxing the whole body, and that's why it can be quite addictive and why GPs do not recommend it long term. Unfortunately, at this time, we don't really have any other alternatives. So some people may still use this in a flare-up. But as we go on through the program and we talk about flare-up management, the physiotherapist will be talking to you about how to manage muscle spasms. So what are some of the side effects that you can experience? Have a think about the things that you've experienced from some of your medications. So some of the main side effects that come up are things like constipation, dry mouth, nausea, indigestion, visual disturbances, sweating, dizziness, sleepiness, mood changes, vivid dreams, feeling disconnected. The list can go on and on and on. And in fact, many medications have very, very long lists of side effects. And the reason for that is that when we prescribe someone a medication, if they report a side effect to us, it then has to be reported via something called the Yellow Card Scheme to the MHRA, the Medicines Regulation. So the older a medication is, generally speaking, the longer the list of side effects will become, because over time, more and more side effects get added to it. So how should you be taking medication for your chronic pain? There are two schools of thought here. The first is that you wait for your pain to get bad and then you take the medication, and this is called pain contingent. Or for others, you don't wait for the pain to get bad, you just take the painkillers at regular times throughout the day, and this is called time contingent. And either one of these ways can work differently for different people, so there's no right or wrong about how people should take it. However, what I would recommend is, if you are somebody that ends up taking painkillers daily anyway, but you're waiting for the pain, then it would be better to take them time contingent to try and level out that pain. If you're somebody who only takes them as and when needed and is not taking them daily, then it is okay to wait until you are getting pain. However, please try not to wait until the pain is very severe or at its worst. As soon as you notice the pain starting to come on, the earlier you take a pain medication, the more effective it is. And just to demonstrate with this graph, so if you are waiting for the pain to get bad before you take your medication, you wait and you wait and you wait, and then you give in and you take the medication here. And it takes a while then to actually kick in because your pain's so bad. And then eventually it will start working and it'll bring the pain back down. Perhaps not down to the level that it was before. Then you wait again and then until the pain's really bad. And again, you take the painkiller and it takes time. And we see these big peaks and troughs. Now, if you can manage to take regular medication, so throughout the day, regardless of your pain, as you can see, generally having some pain medication in the background tends to reduce these peaks and troughs. But as I say, there is no right or wrong. It's what works for you. But if you are taking medications daily, but you're waiting for the pain, it might be worth considering this method. So often people will have concerns with medications, and some of the things that come up are words such as tolerance, dependence, and addiction. And they can often get interchanged and used for the same meaning, but they do all have slightly different meanings. So tolerance is pretty much what anybody would get with any medication that they're taking regularly. And what it means is that you get a reduced reaction to the medication over time. And that we find that often people need increased doses in order to produce the same effect that they were getting with a smaller dose previously. We also note that the benefits of the increased dose lessen, but as the dose increases, we also see more of the side effects and the risks of harm increasing at this time. And sometimes people just have to admit that the medication is no longer providing any benefit for them. Then we have dependence. So dependence is something that people can often get with medications like opioids. And as I mentioned earlier, so the antidepressants and the anticonvulsants can also cause dependence. And this is a physical dependence. So what happens is the body becomes physically reliant on this medication. And if you suddenly miss a dose or stop the medication without tapering it off slowly, then people can experience withdrawal. And withdrawal is a really unpleasant physical sensation. You can get intense anxiety, agitation, shivering, abdominal cramps. And one of the other side effects of withdrawal that often comes up is increased pain. And that can be quite confusing for people, because if they stop taking their medication and then their pain gets worse, one would assume that the pain medication was then working. But that's not necessarily the case, because it may be that the pain has increased due to withdrawal as opposed to the medication actually working. So the safest way to find out if your medication is working is to reduce it, but very, very slowly, to give your body a chance to come off it slowly and not go into withdrawal. And then we have addiction, which is something that people often worry about. Generally, we find only a very small amount of patients that are taking opioids or benzodiazepines actually become addicted to these medications. Addiction is very different to dependence in that it's not just the physical dependence, but it's a disorder of the brain's reward system. And it can occur when you're taking high doses of opioid medications over time. It also occurs with other substances like alcohol and illegal drugs. But typically, there's a strong desire to take the drug, difficulties controlling its use, persistent use despite harmful consequences, and progressive neglect of other pleasures, interests, responsibilities. And what happens is that a higher priority is given to the drug than any other activities or obligations. So, drug driving law is something that came out in 2015. What the law says is that so long as you are following the advice of a healthcare professional and your driving isn't impaired, you can continue to drive. The new law sets limits at very low levels for illegal drugs such as cannabis and cocaine. However, it does set the levels for prescribed drugs much higher. I guess it's important to say that if you are on medications that are known to have a side effect of drowsiness and you are in an accident, obviously they will be wanting to test to see what levels of drug you have in your system. My advice is that if you are taking these medications and you feel at all drowsy, whether it's to do with the medication or not, I would advise not to drive. And whenever you're started on a new medication, it's sensible not to drive until you know how you react and respond to that medication. Okay, so just to recap on what's most important for you with your medications, what we want to aim for in the longer term is for people to be on the lowest possible dose with the greatest benefit and the least side effects. Now, in order to do that, we want to work with people who are perhaps on some of the higher doses and look and see if we can try and reduce those slowly without any impact on your pain. And the aim longer term would be to be using medications for flare-up management rather than everyday use. But this will come in time once you've started to learn all of the other pain management strategies that you are learning as part of the program. Thank you for listening.